All right. Thank you, Shubham. Yeah, thank you, Shubham. So a very warm welcome to you and very good evening. So we have reached this Webisode session, this 32nd Webisode session in Decoding GI-HPB Oncology. So over more than a year, and we have covered so many topics till now on GI and HPB Oncology, and now coming to the miscellaneous session, where today's topic of discussion is basically cytoreductive surgeries and HIPEC in GI-HPB Oncology. So very interesting topic, some gray areas, a lot of gray areas actually, and which needs a worth mentioning and discussion. And we have eminent faculty with us today for that discussion. And I will be inviting Dr. Sanket Mehta, who is a surgical oncologist in specialty surgical oncology hospital, Mumbai. We have with us Dr. Sanjeev, who would be handling a panel discussion, who will be moderating. Dr. Sanjeev was earlier in Max, and now he's a senior consultant surgical oncology in Manipal Hospitals, New Delhi. And I welcome. And we have Dr. Syed Assif Iqbal, who is a surgical oncologist from Rajiv Gandhi Cancer Institute, New Delhi. We have Dr. Ajesh Raj, who is from Indo-American Cancer Hospital, Hyderabad, and Dr. Diwakar Pandey, who is from Balco Medical Center, New Raipur. So I welcome you all in this webisode session on cytoreductive surgeries and role of HIPEC in GI-HPB oncology. So taking forward this discussion, I invite Dr. Sanket to deliver a lecture on overview, indications, and techniques regarding CRS and HIPEC. Welcome, Dr. Sanket, and you can take over the session now.
Thank you. Thank you so much. Very kind of you to invite me for this talk. And congratulations for organizing such an important academic session. It's really gratifying that you could manage to do all these things during the pandemic and carry it forward even after that. So thank you so much for inviting me. Really happy to be a part of this program. Can I share my screen? So is it visible?
Yeah, it is visible. Yeah.
Okay, thank you. Thank you. So quickly, just to give an overview, like why is this topic important? And I always, kind of to put things in perspective, let's talk about the disease burden. For a city like Bombay, where I am from, we have a population of approximately nearly 2 CR. And if you calculate the time-adjusted incidence of patients, in this population, we would see that we have 20 pseudomyxomas, 20 mesotheliomas, 600 colorectal cancers with peritoneal metastasis, 800 ovarian cancers, about nearly 150 gastric cancers, although I suspect the incidence would be a little more than that. And of course, nearly 200 rare diseases. So we're talking about nearly 2,000 patients every year from Bombay City alone. So which is not an insignificant number considering that these patients may be treatable with surgery, and which is why I think this modality or specialty is extremely important. Let's now go to the one disease where it all started. I mean, it started with pseudomyxoma peritoni, which was the initial disease which had some really dramatic results demonstrated by Dr. Paul Sugarbaker from from at that time in NIH, and now currently he is in Washington DC from Nestor Memorial. So when it comes to pseudomyxoma peritoni, we all know that 95% of the pseudomyxomas are of appendiceal origin, and CRS and HIPEC is the treatment of choice and mainstay in the treatment. But when we talk about pseudomyxoma, there are two important experiences apart from that of Dr. Paul Sugarbaker, which needs to be considered. And that is the SOGI studies and the studies from Basingstoke, because this summarizes the entire notion of CRS and HIPEC in pseudomyxoma peritoni. The two important studies from SOGI group, which I really think are landmark, is this one, which is a huge database of nearly 2,300 patients from 16 expert centers. And you can see acceptable morbidity and mortality results. Mind you, this study includes the learning curves of these centers, and since they were pioneer centers, actually the learning curves were much more steep than what it is for us right now. And you can see, look at the median progression-free survival of 8 years and the overall survival of 16 years with just one surgery and IPEC given at the time of surgery. When we come to the negative prognostic factors, and I think these are very important, apart from the disease-related, prognostic markers like the we find that patients who have received prior chemotherapy, who have had post-operative complications, or who have poorer survival outcomes compared to patients with and HIPEC. So you can how important it is, concentration of in expert centers, the complication rates can be kept low, and CRS, complete CRS and HIPEC can be performed for most comers. So I think that study really laid down the basis for cytoreductive and HIPEC. And the second very important study, which I think really puts into perspective the complexity of the surgery, is this learning curve study. Again, several centers participated, and very interesting criteria for assessing learning curve. Rates of optimum cytoreductive surgery, which is an assessment of the surgical skill involved. Yes. Yeah. The second is the presence of, the incidence of severe post-operative morbidity. So, this again assesses the learning curve of the institute in managing the post-operative complications and early oncological failure, which is indication of the case selection. And we find that of the 33 centers and 47 surgeons who were assessed, only 8 out of the 33 centers and 6 out of the 47 surgeons completed the learning curve in 6 surgeons was 96 cases. And the average for the entire group was 130 cases. So you can imagine that it's a very long learning curve. And if you're going to do around 8 to 10 cases every year, it is going to be a decade before you complete the learning curve. So it is important whoever on the specialty and try and increase the case volume so that you can quickly get through the learning curve and do justice to the patient. Sorry. Next experience, which I really think is important, is the Basingstoke experience. For the uninitiated, I'll let you know that Basingstoke was one of the very first centers who started doing only cytoreductive surgeries as a specialty. It was funded by the NHS, so all patients from UK would come to the Basingstoke Center, and there are very interesting learning curve studies published. But what I want to point out is these 2 studies, one of which is about recurrences of the 500 odd cases that they assessed retrospectively. 25% of the patients had recurred, and only 25%. So 1 out of 8, 1 out of 4 of each of the patients that recurred were amenable for a complete CRS and HIPEC at the time of diagnosis of recurrence. And among these patients, they found that those patients who could undergo a complete CRS and HIPEC had a very good 5-year survival even after the second surgery. So it's important that we follow up these patients, and if a reiterative surgery is required, we offer that to the patient to further extend the survival. The second of these studies is where, is not
Dr. Assif here. The audio is broken. I don't know whether the problem is with me or problem is different. The audio is
No, I
broken.
think it's Dr. Mehta's internet connection.
Yeah.
Okay.
I will just.
Dr. Sanket, sorry to
Dr.
interrupt in between.
But
Can you
even in these
adjust your network
patients, when
connection?
they did low risk maximal debulking surgery, they found that 39% of the patients survived for more than 5 years and 8% even survived for 10 years.
Dr. Mehta, is my voice audible to you? I think he has lost the connection. So
He'll rejoin. We'll just wait.
yeah. Dr. Nikhil, will you be calling him?
Yeah, I'm
Just
doing
to
that.
confirm? Okay.
I'm doing that. I'm doing that.
Okay.
Hello, can you hear me?
Yeah, we can hear you now.
Yeah. I'm so sorry. Just give me a minute to share once again.
Yeah, sure.
Okay. I don't know till where I was audible. Can I continue with colorectal peritoneal metastasis?
Yeah.
Yeah. Okay.
Yeah, yes, please. Appendiceal neoplasm slide you were sharing at that time, the data.
Oh, okay. So I just completed that. We completed the 2 studies of the Basingstoke group where we saw how, doing reiterative surgeries as well as doing maximal debulking surgeries for where a complete cytoreduction is not possible also adds to survival. So I think that completes what I think is the important evidence in the field of pseudomyxoma. Coming to colorectal cancer, peritoneal metastasis, which I think was, or rather, the commonest indication for cytoreductive surgery and HIPEC until 3 years back. And the reason for this interest was because of this study, which was a Dutch randomized trial where they randomized to just then
The audio is gone again.
Yeah, Dr. Mehta, there is some network issue probably at your end. So if you can check it out.
Which was versus cytoreductive surgery and HIPEC. And they found
Dr. Mehta, is my voice audible to you? Yeah, I think network issues are there with him. So we'll wait for a couple of minutes and see if that can be corrected.
No problem.
So I've spoken to Dr. Sanket. There are network issues at his end. He is trying to sort this out, and
Sure.
there's nothing we can do in the meantime. So we just wait.
Yeah. So just can we have a informal discussion with the panelists? Okay. I mean, what are the challenges they face actually while deciding in their tumor board and all? Yeah. Dr. Sanjeev, if you can take over for a couple of minutes till Dr. Mehta joins back. Yeah.
Yeah. So last webisode we had a detailed discussion about pseudomyxoma peritoni, a particular cancer's role of HIPEC. So this time our main aim is to discuss more about GI cancer, especially colorectal, gastric cancers, hepatobiliary cancers. What is the role of CRS HIPEC? And there are so many gray areas, rightly said by Dr. Sefali in the beginning. And this panel discussion and this episode is mainly for this the students. So it won't be much in great detail, but colorectal peritoneal metastasis is a challenging issue. So it all started from a positive trial by Dr. Vic Webrel, and then recently published PRODIS 7 trial in which which was a negative trial. So there has been a lot of changes. So whether to do HIPEC, whether to consider HIPEC in colorectal peritoneal metastasis or not. So it's a big question. So we really don't know what is the current status of this HIPEC in managing peritoneal metastasis for colorectal cancers. So there are many drawbacks with that study, but we need to discuss and understand what should be the rationale of considering HIPEC for colorectal disease, because initial studies by Dr. Vic Webrel showed that the survival in these patients in whom CRS HIPEC is considered, the survival is as good as a resectable liver metastasis for colorectal cancer. So these things should be discussed and understood. Sir is back. I think Dr. Mehta is back.
Yeah. So, Dr. Mehta, can you hear us?
Yes, can you hear me now? Can you hear me?
Yeah. We can hear you now. Yeah, it's better. Yeah.
Okay, great. So coming to colorectal, yeah. Sorry for all this disturbances. So in the colorectal, the initial interest started because of this multicentric Dutch study, which I think you was just referring to. Is in this study they found that patients who underwent a complete cytoreduction with HIPEC, had a 41% 5-year survival, which was far superior than what was the then available best chemotherapy in the palliative setting. And these results stood ground even after 8 years of median follow-up of these patients. So these were not just extrapolated results, these were actual results of these patients. And that's why it became a very common indication for CRS and HIPEC. After that, there were several studies, including these multicentric French studies, which looked at and which had similar results with 3 and 5 year survival between 30 to 40%, and especially for patients who underwent a complete cytoreduction. When they compared this with median survival of patients undergoing complete resection of colorectal liver metastasis, they found that the 1, 3, and 5-year survival were absolutely identical for patients who underwent complete resection of liver metastasis versus patients who had complete resection of peritoneal metastasis. So if without any randomized trial, we accept liver resection as the standard of care for liver metastasis, why not peritoneal metastasis? And I think there is a very sound logic for this. So it became the standard of care, but we really did not know what was the actual role of HIPEC in the entire gamut of cytoreductive surgery and HIPEC. So this was the question that that really needed to be answered. I had the privilege of working with Dr. Francois Kenny, who was the principal investigator of this Project 7 study, and this study was actually conceived when I was working as a fellow in his unit. And so in this study, there was a randomization that performed intraoperatively of complete resection or incomplete resection of all peritoneal metastasis, and the patients were randomized to HIPEC or no HIPEC. And what they found was, and what the assumption was, that the median or overall survival would improve from 30 months to 48 months for patients undergoing HIPEC over and above that produced by just cytoreductive surgery. Mind you, the number 30 months in the assumption had come from one single study of 60 patients by Dr. Dominic Elias. So probably the assumption was not as robust as what it should have been. A single dose of intraoperative HIPEC increasing the survival by 18 months was too presumptuous. And what they found in this study was that in these patients, which both the groups were very well matched, the mortality was acceptable. The 30-day morbidity was no different, but the 60-day mortality morbidity was higher in the HIPEC arm. And when they looked at the median progression-free and overall survival, there was no difference. The overall survival in both the groups was 41 months, which was exactly identical to the Dutch multicentric study. So, in this study, they found that oxaliplatin-based HIPEC did not improve survival in patients undergoing cytoreductive surgery and HIPEC for colorectal peritoneal metastasis. Actually, this study really spelled doom for HIPEC in colorectal cancer. But if you look at it, there are fallacies in this study. And the problem was because this study was conceived way back in 2008, which was really the initial experience of HIPEC. In this study, there were 20% of the patients who had PCI more than 20, which we now know do not benefit from cytoreductive surgery also, let alone HIPEC. We also, in this study, the assumption of a median survival of 30 months was wrong, because even the patients who underwent cytoreductive surgery had a 41-month median survival, which I think is the positive take-home message from this study. And the third fallacy was the short oxaliplatin-based HIPEC. The heat component of the HIPEC did not get enough time to act, because it was a 30-minute HIPEC with only oxaliplatin as the drug of choice for doing the HIPEC. Again, the studies for oxaliplatin, the pharmacokinetic studies for oxaliplatin was again a single institution experience. So a lot of assumptions made, which were probably proved wrong over a period of time, and which is why the study was not positive. What about the other commonest drug that is used for HIPEC in colorectal cancer? That's mitomycin. We know for a fact that the pharmacokinetic studies for mitomycin are robust. We know that it is much lesser morbidity than oxaliplatin. We know that in the mitomycin HIPEC, we give the heat component for 90 minutes. So perhaps HIPEC still has a role, but with mitomycin and in selected patients. The unicancer study, the Project 7 study, also showed that the subgroup of patients which had benefit was in the mid PCI range of 10 to 14 PCI. So perhaps selecting the patients well, especially in mucinous tumors, fit patients, and who can afford a HIPEC, giving a mitomycin HIPEC at least will do no harm. And perhaps it may even portend some survival benefit. So this is the actual indication that I use in my practice. A fit patient, mucinous histology, a PCI less than 15, and who can afford the treatment, we would go and give the HIPEC after a thorough counseling of the patient. Next, sorry. Ovarian cancer is not in our topic today. I'm so sorry. Coming to stomach cancer, which I think is a very, very good indication for cytoreductive surgery and HIPEC. And there is a lot of data in several time points in the treatment of stomach cancer. We have the multicentric French study, which looks at 15 institutions with more than 150 patients, and they had, a median survival of around 18 months, which may not seem very promising, but look at the number of 5-year survivors. They had 20% 5-year survivors in this study. No treatment apart from cytoreductive surgery and HIPEC gives a 5-year survival for a patient with peritoneal metastasis. When they further studied these patients, they found that the patients who had these, who were in the 5-year survival group, majority of them had a PCA of less than 6. So doing a staging laparoscopy for patients with stomach cancer to diagnose early peritoneal metastasis and offering them cytoreductive surgery and HIPEC may actually give long-term survivors and even a potential cure in stomach cancer. What is also important is that now they have recently, at least in a meeting, presented the expanded data of more than 300 patients, and they find that these survival statistics stand, where they still have 20% 5-year survivors. In that 5-year survival group, they have at least 25% patients with signet ring cell histology. So even in the aggressive histology, if detected early and given good surgery with HIPEC, these patients do have long-term survival. A word of caution out here, because we are dealing with stomach and a lot of these patients will need a total gastrectomy. The mortality of these patients is much higher compared to most other sites. CRS HIPEC mortality rates of less than 2%. For stomach cancer, it's nearly or more than 6%, which I think is important while considering this modality. Next, we also have this small but significant randomized trial from China, Dr. Yan, who had published this very long back, and the small number of patients is because the ethics committee stopped this trial prematurely because of the significant positive result in the HIPEC group, where they found that patients undergoing CRS and HIPEC for peritoneal metastasis had a much better, although it's only in a few months, but a much better overall survival compared to patients without HIPEC. So that's what we have currently in terms of randomized evidence for established peritoneal metastasis. But we do have 13 other randomized trials which have looked at some form of intraperitoneal chemotherapy, including HIPEC, in the prophylactic setting, as in the preventive setting, where you have a high risk of peritoneal metastasis or a cytology positive, and a HIPEC or intraperitoneal chemotherapy or EPIC is given, some form of intraperitoneal chemotherapy, and all these studies have a positive result in favor of intraperitoneal chemotherapy. If you look at the forest plot, you find that almost all studies in every single type of intraperitoneal chemotherapy shows benefit in the chemotherapy arm. So I think there is definitely something about intraperitoneal chemotherapy that works in stomach cancer, and we should, in the prophylactic setting, and we should definitely explore this option. Although all these studies are from the Oriental nations, and maybe some studies overdue in our country in the randomized fashion to look at the role of prophylactic intraperitoneal chemotherapy. Now, what about patients who have extensive peritoneal metastasis? We saw from the French study that the PCI more than 12 does not benefit from CRS and HIPEC. So can we do something for these patients? Yes, we have two important modalities. One is something called as NIPS, which is neoadjuvant intraperitoneal port-directed with combined systemic chemotherapy. And this was championed by Professor Yonemura from Japan. If you see the results of these patients, 96 patients, all with ascites or positive peritoneal cytology, where complete CRS was not possible with a PCA of more than 15, which was his cutoff. They found that in the cytology terms negative in 69%, and 30% of the patients actually, after multiple cycles have a complete response of peritoneal metastasis to the intraperitoneal chemotherapy, and CRS was possible in about 70% of these responders. So I think this is really important. If you look at the survival statistics, patients who underwent CRS and HIPEC after completion of NIPS had a 24-month median survival, which is quite significant. And in the non-NIPS group, where they underwent direct cytoreductive surgery, the survival was far inferior to the NIPS group. So this is a very significant, even though it's a retrospective study, it's a very significant study, which I think is easily replicable in our setup. What about patients who have got heavy nodal disease? So again, Dr. Yonemura studied the effect of NIPS on nodal disease, and they found that in patients who underwent NIPS, the number of positive nodes was much lower than patients who underwent direct surgery without NIPS in the setting of peritoneal metastasis. So I think it makes a lot of sense to use NIPS even if the patient has got nodal burden and peritoneal metastasis, because it can potentially render these patients for a chance for surgery. A quick word about peritoneal mesothelioma in the interest of time. We have this again accumulation of patients. When the study was published, they had 500 patients, but now the mesothelioma registry has more than 3,000 patients with an approximate 50% 5-year survival with complete CRS and HIPEC. A point of importance, the sarcomatoid or the biphasic mesotheliomas need a lot of deliberation before subjecting them to surgery, because these are much more aggressive histologies and with poorer outcomes. So epithelioid and the low-grade mesotheliomas are the ones which are the best indications in the mesothelioma group. Coming to cytoreductive surgery itself. So now, since we are going to talk about the technique, we have to understand that the aim of cytoreductive surgery is no visible residual disease. We also have to, kind of use our technique in such a way that we minimize complications, and we should maintain good hemodynamics to ensure good outcomes during the surgery, and the judicious case selection so that all the patients benefit from the surgery. So the first step in the cytoreductive surgery is the assessment of the PCI. Sometimes this can be done by a laparoscopy, or otherwise, once you open the abdominal cavity, it's a visual examination of the abdominal cavity to assess the extent of the peritoneal metastasis. For the students, the abdominal cavity is divided into 9 different quadrants, and then the small intestine is divided into 4 divisions: upper jejunum, lower jejunum, upper ileum, lower ileum. And each of these regions, the 13 regions, is scored for the size of the deposit from 0, which is no tumor seen, to LS3, which is more than 5 centimeter size tumor or confluent plaque-like deposits. And we have several studies using this peritoneal carcinomatosis index, which are in colorectal cancer, in stomach cancer, as well as in ovarian cancer, which have shown that it is also of the survival, which is why using the PCI cutoffs is important to ensure that the patients are well selected and have a good outcome. Often, the surgery starts with extraperitoneal peritonectomy, especially in pseudomyxomas and mesotheliomas, where you want to remove the entire diseased peritoneum. And doing this, where you go in the extraperitoneal plane and dissect the entire peritoneum all the way over the diaphragms, into the pelvis, and over the gerotas fascia, speeds up the process dramatically. You always have the pelvic peritonectomy. It can be rectum preserving. So if the rectum does not have any peritoneal deposits, you can do this. You can see the nice vaginal stump where the hysterectomy with the pelvic peritonectomy has been performed. Sometimes, however, if the rectum is involved, you have to do an anterior section with it. And you can see the ureters nicely dissected. For the students, it's important to preserve the facial layer of the ureter, which contains the blood supply to the ureter, because in case you denude the ureter too much, you may develop a delayed ureteric leak. So it's important that we maintain the planes when we are doing this dissection. The peritoneal stripping, it's for the diaphragm is actually, once you get the technique right, it's pretty straightforward. Often you have, most of the times you don't need to resect the diaphragm, but even if you have to resect the diaphragm, after the peritoneum is removed, the diaphragm sutures very well. You have to understand that the dissection has to go all the way up to the IVC. So you reach the tendinous portion of the diaphragm, dissect up to the IVC. Laterally, you go onto the Gerota's fascia, and then onto the adrenal, and then up to the level of the IVC. That's when you get a complete diaphragmatic and subhepatic peritonectomy. So it's important that we follow these rules to ensure that we are not leaving behind any disease. Regarding resection of the diaphragm, if you end up resecting more than, say, 10 centimeters of the diaphragm, sometimes the diaphragmatic edges may not approximate, in which case you can use either a organic mesh or a tensor fascia lata. I often use the tensor fascia lata because it's natural. It gives a very easy reconstruction. I'm not worried about infection in a foreign body. So that's the choice for me. Often you find this kind of disease in the subhepatic space, especially in low-grade tumors. So although it may initially look daunting, but if you do carry out the extraperitoneal peritonectomy and extend the dissection onto the Gerotas and then do a right hemicolectomy in continuity, you can get rid of most of this disease, as you can see in the after photograph of this, the same patient. The left diaphragmatic peritonectomy is, I think, a little more complex than the right side because you have to go behind the spleen and take out the fascia, the peritoneum over the Gerotas behind the spleen. Sometimes in recurrent cases, you may have disease involving the capsule of the pancreas or the substance of the pancreas, in which you may have to remove the capsule or sometimes even the distal pancreas, which and need to be careful. When you have deposits in the splenic hilum, you need to go by the posterior approach to ensure that you're not injuring the tail of the pancreas, because a pancreatic fistula with a peritonectomy will have a 50% mortality if a pancreatic fistula develops. Of course, you have the world famous omentectomies, and you can have some really impressive sizes, especially in pseudomyxomas and sometimes even in mucinous colorectal cancers. I think a well-done omentectomy may sometimes even require a colonic resection in case it's infiltrating or there are not good planes. The single most important area, which I think is the most difficult, is the lesser omentum or the gastrohepatic ligament, where you have so many important structures packed in a very small area. I think this is the part of the surgery that differentiates the men from the boys. Sometimes it may take an hour just to do this part of the dissection alone. You have the mesenteric disease. If you have a disease like this, which is predominantly mucinous low-grade deposits, for sure that you can remove this with scissor and scissor dissection. Sometimes you may have segments of the bowel involved with disease like this and the rest, which is okay. And you can do a segmental resection of the bowel. But if you have disease, plaque-like deposits like this, for sure that this is not going to be resectable, and it's a contraindication for complete surgery and for not in GI tumors, but in ovarian cancers. Sometimes you have to do a retroperitoneal dissection over and above the peritonectomy. But occasionally it's worthwhile to push the limits of the dissection to, especially even in aggressive tumors, when there is vascular involvement, but the PCI is not too high. We have done a few of these, like for example, this patient's where we replaced the aorta for a colonic tumor, which was going through the mesentery and involving the aorta. This patient survived for 4.5 years after the surgery. So really gratifying results. This was another patient who is alive and well after 7 years, a colonic tumor with local recurrence and a PCI of 5 infiltrating into the common vessel. We did vascular section and grafting. And something like this, where we had to remove part of the distal pancreas, nephrectomy, and colonic resection along with a part of the stomach for, again, a colonic tumor. And this lady survived for another 3 years. So extended resections can also be done in highly selected patients with good results, even in GI tumors. Finally, once the resection is done, of course, you have the HIPEC, which is probably the simplest part of the surgery. In our unit, it's done by the junior most surgeon, where everybody takes a lunch break. And it just involves spraying the chemotherapy within the abdominal cavity. I favor the open technique because it saves time. It's very much under control. Even a junior guy can be there and ensure that, there are no suction or hot spots, and everything is done adequately. You don't have to spend the time to close the abdomen and lay down the temperature and monitor it too closely. So for me, open HIPEC works. Enough studies have been done to show that open HIPEC is safe and for the OT personnel. What about, again, I cannot stress enough the importance of the learning curve. You have to be in a high volume unit to train and become a high volume unit once you start doing the procedure. We ourselves did our own learning curve using the LCQSM method, and we found that for complications, the learning curve evened out at 70 cases, but for early recurrences and 90-day mortality, the learning curve was more than 150 cases. So you need to be sure that you're working in a high volume unit. Quickly regarding, I think as a community, we should concentrate on pooling our data and trying to create our own guidelines and studies to guide what we are doing. We should not be relying on just the Western data guiding us. We have taken our own initiative. Me and Aditi have been collaborating along with all the several other surgeons. Some of you also did. This is to set up these really important studies. Initially, we started with just retrospective studies and description of techniques and learning curve studies. But as things moved along, we started collaborating with international centers. We've been doing studies on extended resections for ovarian cancers, HIPEC, failure to rescue studies. And, we have even got recently a publication in Annals of Surgical Oncology for performing total periparietal peritoneal for all patients with for interval cytoreduction. So I think we need to study our own data and perform these studies in a collaborative way to ensure that we also overcome the deficits in the current evidence. As a part of our own thing, we also have a fellowship program, which I think all of these institutes, especially Max, has. And I invite everybody to join the Indepso network and contribute to the Indian HIPEC registry. Thank you. Thank you so much. Yeah. And apologies once again for all the disturbance. Really sorry.
No worries, no worries. So it was a very nice, comprehensive presentation and discussing all the aspects. So I'll take a couple of questions if they're there. Okay, so there is one question in the chat box. Dr. Mehta, if you can take, can HIPEC be beneficial to peritoneal carcinomatosis due to cervical cancer?
So the rare diseases, the registry has looked at this question. The results are not gratifying. I think cervical cancer is a strict contraindication. All histologies, none of them did well. So I think we should not do that.
Right. And what cutoff of PCI do you use for CRS HIPEC in colorectal and ovarian cancer?
So in colorectal, for me, the cutoff is 15 or 16. There have been enough studies which have looked at this. I think several countries have their own cutoff. The Dutch use 12 as the cutoff. The French use 16 as the cutoff. Americans use 20 as the cutoff. I think there is no, you have to understand this cutoff is a guideline. Like, for example, you have a patient who has got a PCI of 10, but the entire small bowel is involved. It's still a no-go, right? Whereas if you have a mucinous histology, the PCI of 20, a patient in subacute obstruction, and a young patient where a complete cytoreduction is possible, I would go ahead and do the HIPEC. So it's something that is just a guideline. I think for us, 15 works for most cases. Yeah. And for ovarian, I think I don't see it as a cutoff so long as you can achieve a complete cytoreduction. You've done PCI 30, 32 as well. So long as you get a complete cytoreduction, I think it works.
Right. So basically the complete R0, I mean CC0 is the goal actually, if you can achieve that.
Yes, precisely.
Yeah.
Precisely.
And how do modalities like HIPEC compare with NIPS?
Yeah, so, HIPEC, we have only one real study looking at HIPEC in gastric cancer as a kind of a neoadjuvant setting modality. So they had 160 cases. This was a study from Lyon. 160 HIPECs performed for 48, if I'm not mistaken, cases, of which approximately 15% actually reached the stage of surgery. And all these patients did systemic therapy. So we really don't know whether it was just the systemic therapy or the systemic therapy and HIPEC combination, which was good. We still don't have a randomized trial for it. But yes, it's a promising modality because among the patients who undergo the HIPEC, some of them have durable response with HIPEC. I myself had a gastric cancer patient who received 7 with control disease during that period, which is like 15 months of control with just no systemic therapy. So I think it's a very promising modality in palliation. As a neoadjuvant treatment, the word is still out. I think we'll have to wait.
Yeah, in
hello, sir.
Hello,
Dr. Assif from Rajiv Gandhi.
Yeah.
Good evening, sir.
Yes.
Thank you for a very comprehensive look on this. I had a question. You said that PCI is not absolute, contraindication. I wanted to know if you are doing patients with significant ring cell histology also who have PCI more than 50? Because we stopped doing it.
Yeah. So for signets, I would not do for PCI more than 10. I mean, I would not even.
Okay.
So as I said, mucinous is one caveat where doing a complete cytoreduction with HIPEC makes a world of difference. Again, we don't have randomized trial evidence for it, but every expert center expands the indication when it comes to mucinous histology. So yes, but again, if it's a pure signet, then I think all of them do badly.
Yeah, that's true. Because initially we had also started doing it almost non-selectively, but of late we don't do after PSDSS of more than 10, we don't do HIPEC in these patients.
Absolutely, completely agree.
Dr.
Nikhil, any more questions or should we take on to the panel?
No, I guess we can move on to panel. It's already around 8. Sanjeev, quickly.
Yeah.
My apologies once again.
No worries.
Please, thank you.
No worries.
Yeah. So quickly moving, am I audible?
Yes, Sanjeev.
Quickly moving on to the panel discussion. So I'll try to keep it simple and interesting for the sake of the students. So panelists, we have Dr. Sanket Mehta, who needs no introduction. He's the pioneer of HIPEC CRS surgeries in India. And we have a trio of 3 young and dynamic cancer surgeons from different parts of India. We have Dr. Assif from Rajiv Gandhi, New Delhi. We have Dr. Ajesh from Indo-American Cancer Hospital, Hyderabad. And we have Dr. Diwakar Pandey from Balco Medical Center, New Raipur. So we'll be discussing about, about CRS and HIPEC in GI cancer with 3 practical case-based scenarios. Okay, so moving on to case 1. So a 52-year-old gentleman, good performance status, evaluated
Dr. Sanjeev, sorry, can you display it in the slide set manner rather than
No, it's in the slide set manner.
Achha, probably
probably
I'm seeing all right.
So it's in your Zoom setting. So evaluated for alteration in bowel habit, scopy was done, growth at rectosigmoid, biopsy, mucinous adenocarcinoma, CEA was 52. So CT revealed a mass in the rectosigmoid with deposits in the left lower peritoneal deposits, paracolic deposits, and a few pelvic deposits. So the patient received 6 cycles of Folfox, and then he presented to us. So a very common scenario with which a patient of metastatic colorectal cancer, peritoneal metastasis, presents to the clinic. So diagnosed with peritoneal metastasis outside, received some chemotherapy, and then the patient comes to us. So this is a very practical and common scenario. So Dr. Ajesh, when such patients comes to you, how do you evaluate these patients?
Yeah, Dr. Sanjeev, the slides are not moving. Can you just?
So yeah, so this is a 52-year-old, good performance status,
And is
serous adenocarcinoma.
Yeah.
So
Dr. Sanjeev, please change the mode. I think slides are not moving. We cannot see your slide.
I think you have to share your slide on the screen properly. That is not happening.
not happening?
Yeah, so we are just stuck with the first page actually.
You need to change the option slide share in the share screen. You should select the option of the PowerPoint. That would be better. Maybe stop share again, go to the share, and
Is it happening?
the option of the
No, not yet.
Not okay. I'll stop again and again reshare.
Yeah.
Okay. So share my screen. So
that select the presentation.
Yeah. Again in the same mode, but let's see if it is moving.
is it moving?
Not moving. No, Dr. Sanjeev. Probably PowerPoint and then, share your screen. Yeah, it's moving now. Yes.
So let it be, no, just a second.
Okay.
Share.
I think, why don't you use the present button? Maybe that might work. Yeah.
Yes, probably.
Is it changing now?
No.
No.
Please move your slide. Then we'll come to know.
Yeah, I'm moving it. No, not happening.
No, it's not changing then. No.
So Sanjeev, when you present, you have to present the presentation. I mean, there will be two screens there, in which one will be this and one will be the presentation mode.
Yeah, it's in the presentation mode only.
I think if you click on the slide, it is visible to us. So why don't you click on the slide on the left side? Yeah, just as you did right now for case one.
Yeah.
Yeah,
Yeah.
that will work.
So
Yeah.
let it be. So okay. So 52-year-old gentleman diagnosed with a mucinous adenocarcinoma rectosigmoid. CT scan shows some deposits in the left lower peritoneum or the left lower peritoneum, paracolic gutter, and pelvic deposits. So he received 6 cycles of Folfox, and this patient came to the OPD. So this is a very common scenario where the patient is diagnosed with metastatic colorectal carcinoma with peritoneal metastasis, and patient receives some form of chemotherapy outside, and then this patient comes to the OPD. So Dr. Ajesh, how do you assess these kind of patients?
So first and foremost, 52-year-old male, carcinoma rectosigmoid, post 6 cycles of chemotherapy. Original CT to start off with has a pelvic peritoneal disease confined to the pelvis. I assume that the PCI is low. This patient we would like to reevaluate once again, repeat the CEA, get a PET CT to rule out extra-abdominal disease, and as well to look at the resectability. And we would also do review the blocks and slides to see what histology it is. Repeat the CEA and as well as get the RAS and RAF mutation panel done.
So what imaging modality do you use for assessment of these kind of patients? CT scan, PET scan, or MRI scan?
This patient, I would like to rule out extra-abdominal disease as well. So I would prefer a PET CT in this scenario.
So Dr. Diwakar, so your imaging. Yeah.
My preferred imaging again would be PET CT, but I would like to supplement it with MRI also. We have started doing it recently for some of our patients, especially with mucinous variety of tumors, where you might pick up some on the flare fat suppressed images, you can pick up some disease which is actually not seen on the PET scan. So I might supplement it with MRI as well, PET with MRI.
So, Dr. Assif, any difference of opinion? You
No,
always do
not-
PET scan or just a CT scan?
No, a good quality CT scan of the thorax, abdomen, and pelvis suffices for us. And if there is a doubt of extraperitoneal disease, then we may do a PET scan. Otherwise, if it's a good quality CT scan, thorax, abdomen, and pelvis, we just don't do the PET CT then.
So reassess. Yeah, sir.
Can I add something? Yeah, I think I had some time back done a review of literature on this, and we find that PET CT scan does not change the decision making in most of the patients. So I think it's an overrated investigation. Just to put things in perspective, PET scan, majority of the PET scan machines have a resolution of 18, 16 or 32 slices. You have a CT scan, which is much higher resolution, much thinner slices. You would probably pick up more disease on a good quality CT. So for us, a CT chest, abdomen, pelvis is good. For mucinous histology, sometimes, especially in recurrent cases, we would do an MRI. PET scan is very, very rare. I mean, patients come with a PET scan, that's a different issue. But most of the times, if I were to be the physician ordering the investigation, for me, a CT scan works.
Especially in the mucinous histology that you spoke of, in this case, PET is not going to show it's not going to show any activity. And anyways, they have very low
precisely mucinous and signet both. So I don't think the PET adds anything.
So rightly summarized by Dr. Sanket, and good point by Dr. Assif and Dr. Diwakar. So reassessment was done. So it was a stable disease, low volume disease limited to lower abdomen. CEA was 10. So again, this is a very common scenario. So after chemotherapy, there is stable disease or some kind of mild progression. And then when we are in a fix, what to do. So what next? What should be the intent of this kind of patient, curative versus palliative? Dr. Assif.
I think I would have loved initially if we had a staging laparoscopy to begin with in this patient, because most of the times the subcentimetric disease is not always picked up by CT scan in a good quality CT scans. But keeping in view the present scenario that you're presenting us with, I think it is worth to go ahead with the surgery in this stable disease also. First of all, we'll do a staging laparoscopy, and at that time, if we feel the disease is, the PCI permits a complete cytoreduction, then we'll go ahead with the surgery then.
So, Dr. Ajesh, what is your view? So, patient has received chemotherapy, stable disease. So, what should be the intent, curative or palliative, or some kind of mild progression? Hello?
Hello?
Dr. Ajesh?
Yeah, sorry, I lost you. Yeah, in this scenario, I think intent would still be curative, in my view. Would still consider this patient for a diagnostic laparoscopy.
So sorry, my animation is not working. So that's why it's happening. So this patient underwent, was taken up for staging laparoscopy. So PCI was 8 and it was mostly, localized in the lower abdomen and the pelvis. So Dr. Diwakar.
Yeah.
So what next?
So since the PCI is 8, probably only a good quality cytoreductive surgery is going to be sufficient, but it's mucinous, so I can add up with the HIPEC as well.
So what are your views, Dr. Assif?
Yeah, cytoreductive surgery and HIPEC.
So you want
Primary anastomosis in this case, no stoma.
Correct.
so you want to add HIPEC even with PCI of 8.
Yes, yes.
Dr. Ajesh.
A good cytoreduction. Should
So
be
question
sufficient.
is PCI 8 whether you want to add HIPEC or not.
No.
So only cytoreduction. Sir, Dr. Sanket.
Yeah, I'm more partial towards HIPEC and mucinous, irrespective of the PCI. So I would give HIPEC.
So many a times we come across with post chemo settings. So baseline diagnostic staging and PCI calculation when it is not available, so the accurate estimation of PCI post chemotherapy when there is some kind of response also, this is not accurate. So better to add HIPEC. This is what I feel.
I think what we also need to understand is that all these patients also have, the study which the PRODIS study with the subgroup analysis, the study was not powered for the subgroup analysis. So it's not that, what the results are sacrosanct, that low PCI, no HIPEC, mid PCI HIPEC, high PCI, no HIPEC. So I think we need to take all of that with a pinch of salt. I still feel mucinous histology, we should give HIPEC irrespective of the PCI.
In fact, we also do HIPEC in almost every case. Even if patient has a PCI 2-3 also, we do a HIPEC in every case.
So PRODIS, this was the PRODIS 7, which nicely summarized by Dr. Sanket in his presentation. So this was what we were talking about, the PCI less than 11, 11 to 15 and more than 15. So this mid group, benefited from HIPEC. So, but there were many flaws of the studies. So one more question comes, what is the extent of peritoneal resection in these kind of patients, total versus involved peritoneum? Dr. Assif?
Yes, again, we have not done a laparoscopy in this patient upfront, so we don't know the initial extent of the disease that the patient had. Suppose we had a patient where we had done staging laparoscopy in this patient and the disease was confined to the lower abdomen only, then we may be do a peritonectomy of the involved areas only, maybe pelvis, left paracolic region. But since we don't have that knowledge, we'll like to do a complete peritonectomy also.
So, Dr. Diwakar, any difference in opinion?
No, I agree with Dr. Assif in this, because it's a post-chemo setting patient and we don't have a baseline disease profile on the patient.
Dr. Sanjeev, can I ask one question? So since you are highlighting that this patient had stable disease or mild progression as the best response, so still do you think that, pre-op staging in this particular scenario would have differed from what there is now? I agree with you. Going on a pre-op setting is the best scenario.
So this is a practical situation which we encounter day to day in our clinic. Patient, the baseline PCI estimation has not been done. Patient has received chemotherapy and the patient has come to us. And many a times these patients have this low-grade histologies, mucinous histologies, which are poor responsive to chemotherapy. So we really don't know. We know that this mucinous histologies, the response to chemotherapy is not that great.
Yeah.
So,
and we also need to consider that the patient, the CA of the patient has reduced dramatically. So patient has had a response. CT scan, whether it shows a stable disease or CT scan cannot pick sub-centimeter disease always. So we have to consider
once you have done a staging lab right now. So do you think that it would certainly differ that much, that having a stable disease right now or mild progression, so peritoneum has a significant difference?
Possibly not, but still CA decreasing from 58, 52 something to 10, still we would like to ideally have staging laparoscopy upfront. But in this case, and for me, we will do a peritonectomy, complete peritonectomy.
So can I add something out here? I am a big proponent of total peritonectomy, but in ovarian cancer. The pattern of disease spread for colorectal versus ovarian is dramatically different. There is the precinct study which is going on right now, which is looking at the pattern of peritoneal dissemination in colorectal. But what we know from the studies done by Dr. Shurubaker and all is that unlike ovarian cancer, where the disease has predilection for the parietal peritoneum, it's not so in colorectal cancer. You will still have microscopic disease, which is equal predilection for both the visceral and the parietal peritoneum. So just removing the parietal peritoneum and leaving behind the visceral peritoneum probably does not serve a lot of purpose in colorectal cancer. We also need to put into perspective the prophylocship study where they've done prophylactic surgeries and HIPEC for non-visible disease as risk reduction, and they had no benefit. So doing what is good in mesothelioma or ovarian cancer, which have much higher predilection for parietal peritoneum, and extrapolating that to colorectal, I don't think is the right idea. It is a much more aggressive disease with an infiltrative pattern. So perhaps a total peritonectomy in colorectal may not benefit. I'm not saying it is wrong. I'm just saying may not benefit. So for me, selective peritonectomy or involved peritonectomy works.
Yeah, point well taken, sir. We have the same practice, but for the patients who have presented us first and whom we have done a staging laparoscopy, we do the limited peritonectomy only at our own center. But for those patients for whom we have done a staging laparoscopy upfront, and we have recorded the findings.
Okay. No. Yeah. I mean, as I said, it's
not
like
point well taken.
Right. It's just
it's
a thought
point
process.
Well taken, yeah. I got your point.
Yeah, right. Yeah. So we really don't have an answer, but we have to look at things. So I think there is one study which has published from this. This has been, so sorry, the animation is not working. So this has been published from Bangalore, Dr. Somashekar, which has told that there is decreased recurrence, but again, this the subset of patients are more of ovarian. So now coming to regarding the choice of chemotherapeutic agents for HIPEC. So multiple chemotherapeutic agents. So Dr. Diwakar, what is your choice for colorectal cancers?
So we use two drug therapy. We use mitomycin C with adriamycin. And we don't have any experience of using oxaliplatin we are like using these two drugs for a very long time now. And it's to 43 degrees Celsius temperature, 90 minute cycle.
So Dr. Assif, what is your practice at Rajiv Gandhi?
For most of the patients, we do this only, mitomycin C, doxorubicin, and intravenous 5-fluorouracil leucovorin. We have done few cases of oxaliplatin HIPEC for those patients who had recurrence after HIPEC. We did HIPEC second or third time. In those patients, we have used oxaliplatin.
Okay. So second or third time recurrence in colorectal?
In colorectal, yes, sir.
Okay, after HIPEC.
Yeah, after HIPEC. Re-HIPEC we have done with oxaliplatin rather than 5-fluorouracil, this mitomycin C and this.
So Dr.
3 or 4 cases. Okay. Not more.
Dr. Ajesh, what is your practice at your institute?
This is mitomycin with doxorubicin as well.
Okay. Dr. Sanket, at your institute, what do you practice?
We use only mitomycin.
Only mitomycin.
Yeah, adriamycin, I used it initially for quite a few cases, nearly my first, all the colorectals in my first 3 or 4 years. But on long-term follow-up, we had a few cases of extensive peritoneal fibrosis and obstruction because of adriamycin-induced fibrosis. I spoke to Dr. Shurubaker, and he admits that he also has several such cases. I think it's a very significant complication, which is debilitating and sometimes fatal for the patient. So where we don't have any study to tell us that using a 2-drug regimen is better than a 1-drug regimen, I think for me, mitomycin alone works.
So even I am using mitomycin alone, and even at Max, I think mitomycin alone is being used. Dr. Sefali,
I completely agree with you. I discussed with you that day also. So we prefer single agent mitomycin also in most of the cases. Yeah, in pseudomyxoma.
So Dr. Assif, you are talking about some kind of bidirectional IP plus IV at your institute. So
yeah, at the time of inducing the HIPEC, we simultaneously give intravenous leucovorin 20 milligram per meter square and 5-fluorouracil at 400 milligram per meter square simultaneously. When at the time of starting intraperitoneal chemotherapy.
So anyone else who practices bidirectional chemotherapy for this thing, IP plus IV for colorectal? Dr. Ajesh, Dr. Diwakar?
I used to do it. I used to do it. Till we had 2 cases of DPT deficiency, and one of them with prolonged neutropenia, just with a 400 milligram meter square dose of 5FU. And one of them actually died. His bone marrow never recovered. Since then, and we really don't have evidence stating that using bidirectional is better than using HIPEC alone. Because, like, for example, one of the larger experiences, the Basingstoke experience, they don't use 5FU and they have similar results. So I am more inclined to not using it.
Yeah,
if I do it, I would make sure that the patient does not have a DPT deficiency and do it.
So bidirectional is a bit toxic. So regarding
in our experience, we have experienced, I think we have done around 150 cases over past 7-8 years. 3 or 4 patients had, severe neutropenia that was refractory, but we had a couple of deaths also, but other 2 patients, they recovered eventually with this Rafil and all, but not more than that.
That's the thing, like, for example, if you really want to cut down your mortality to less than 2%, you need to eliminate that one patient, which is a preventable mortality also, which is why I think for me, I think also I was discussing with my medical oncology colleagues, and the DPT deficiency in Indian subcontinent is not insignificant. I think it reaches up to 6%. So we really need to be certain that the patient does not have that, because they go into severe neutropenia with it.
Rightly said, sir. So, Dr. Assif, what is the practice at your institute regarding a technique? Closed, open, or semi-open?
Closed.
Closed technique.
Yeah.
So, Dr. Diwakar, Dr. Ajesh, at your institute?
My preferred technique is open technique, and we're pretty fine with that.
Our preferred technique is a closed technique.
Closed technique.
Yeah.
So plenty of studies and data we have. Both studies are equal, and has been told by Dr. Sanket Mehta also. So it's just a personal preference. So final words, sir, from your side, Dr. Sanket. What is the current status of HIPEC in peritoneal metastasis colorectal cancer?
Needs more evaluation.
So on one hand we have promising studies, the older one and the newer one, which has a negative trial, PRODIS 7.
Yeah, no, I think it needs more evaluation. I think we need to study it more.
More evaluation, because many students are hearing us, and they need to answer this in the exam also. So
yeah, I mean, cytoreduction for sure. We have very, very good evidence now that cytoreductive surgery works. HIPEC with mitomycin has a role, I think, in select cases. I wish every HIPEC done would go into a protocol, into a study to collect evidence, but unfortunately that is not the case. Till then, I think it's a preference. I think we need to evaluate. That's the answer.
Yeah. So quickly moving on to the second case. So again, a very practical, common situation. So a 55-year-old, good performance status. He was diagnosed and treated case of non-metastatic right colon. Underwent right colectomy 18 months back, a PT3 and 2 tumor, completed neoadjuvant chemotherapy. Now on follow-up after a year, so CEA was on rising trend. So it was 72. So a colonoscopy was done, which was normal. CT scan was done, normal. So after that, a PET scan was done. It was also normal. So the patient was taken up for staging laparoscopy. So it revealed peritoneal deposits in the right lower peritoneum, pelvic peritoneum, and ovarian, and also on the ovaries. So it was a limited volume disease, PCI of 4. So what next, Dr. Diwakar?
So if you look at
the approach in such cases.
So if you look at the disease, there's a DFI of more than 1 year. he's a young patient and it's a low PCI disease, probably upfront CRS and HIPEC will be a better option compared to chemotherapy and VSS. But again, some centers give chemotherapy and they do surgery later. Both of them are probably good option, but I would prefer with upfront CRS HIPEC as the treatment of choice, because it's a limited volume, good biology disease, and with a little longer disease-free survival, disease-free DFI.
Yeah, so this is a very common practical situation. Patient recurs, fails on the in the peritoneum, and the patient comes to us. So, Dr. Assif, what is your approach in such cases?
Dr. Diwakar, as he said, it's a low volume disease, possibly a good candidate for upfront HIPEC, also CRS HIPEC. But at our center, our practices for this patient also would be to give a chemotherapy and then reevaluate after 4 or 6 cycles.
So,
we don't do up.
So, Dr. Ajesh?
Yeah, in this scenario with the low volume peritoneal disease, we would prefer an upfront cytoreduction.
So before asking Dr. Sanket Mehta, Dr. Shefali, your inputs on this, I'll ask the medical oncologist.
Yeah, so to, this case we discuss in our tumor board. I also honestly do not have a very clear-cut answer. Both practices do hold true, but personally, I think good DFI, low PCI with a peritoneal disease, I think good way to go is upfront CRS plus HIPEC if it is feasible.
So you're okay with this upfront approach?
Absolutely.
Yeah, so Dr. Sanket.
I'm with my surgeon.
Yeah. On a lighter note, do we practice like this? If a patient has a rising CA and imaging does not reveal anything, we do a staging laparoscopy? At a center, we don't do it unless there is a visible disease. We don't.
Yeah, we also do not do it routinely as a practice. If a scan does not show anything, we don't do a staging laparoscopy as a routine. Yeah.
No, but
so
yeah, please, Dr. Assif.
Again, but my point was, if we don't do a staging laparoscopy in such cases, and if we're doing a laparoscopy for diagnostic purposes, then convincing the patient for CRS and HIPEC at the same time when the patient is in the operating room, we don't find it comfortable. Again, that may be one reason for us not to do a CRS HIPEC upfront and subject the patient to chemotherapy first, and so that he gets time also to make up his mind for the surgery, and we also get the time to know the biology of the disease. Maybe a little bit better.
So, Dr. Sanket, your approach in such cases?
Where do you get these patients, man? I don't get the low volume disease. But if you do, I would do upfront surgery. And yeah, occasionally you do find a patient with rising CEA. I try to reason out with the medical oncologist that we should do a staging laparoscopy. Often I fail, but I think that's if we find something like this, I would operate for sure.
So many a times we encounter such practical situations where the disease fails in the peritoneum. So there are some high risk, colon cancers. So I think one paper was published by you only, Dr. Sanket, where T4 disease, heavy nodal burden, and these patients these patients fail in the peritoneum. So any role of prophylactic HIPEC?
So we have these two negative trials, the promenade and the profellowship. So I think that answer is certain. It's dead. We don't have any role of prophylactic HIPEC. So because both the agents have been tested, so I think it's dead. Yeah.
So profellowship and this Colopec, both negative trials. So no role of prophylactic HIPEC. So quickly moving on to the third case. So 40-year-old male, good performance status, evaluated for upper GI symptoms. So growth in the distal stomach, biopsy, adenocarcinoma, signet ring cell. CT scan done, non-metastatic, distal stomach mass with some perigastric node. So looking early on scans, so the patient was put for staging laparoscopy, but on laparoscopy, there was some deposits on the right hemidiaphragm, PCI of 3. So what should be the intent in such kind of patient, curative or palliative? Dr. Assif?
We will counsel this patient to go for chemotherapy first, maybe 4 to 6 cycles, 4 cycles of FLOT. And we'll tell him at the same time, we'll have a second look after 4 cycles, maybe. At that time, we may do a gastrectomy and HIPEC. If the patient responds well, and on staging laparoscopy also, there is a response. If PCI has increased at that time, then we will not, I want to say, we will not proceed.
So, Doctor,
in nutshell, intent will be curative as of now, and depends upon the response to the neoadjuvant treatment.
So, Dr. Ajesh, what is your practice?
Yeah,
Do you treat these patients with curative intent? Or?
Small volume peritoneal disease at this point of time, intent would still be curative, but following the diagnostic laparoscopy, and we would also take consider this patient for chemotherapy and then reassess again.
So, Dr. Diwakar.
So, Dr. Sanjeev, again, one question. I mean, we have a long discussion on such kind of cases. So, what is your all opinion that what is the time frame that you select the biology in such patients? Is 4 FLOT, that is 2 months of chemo, enough in a peritoneal metastasis, signet ring cell, stomach? So, I mean, we still land up in good debate and sometimes reach a conclusion, sometimes not. So what is the exact time frame we are looking to select a biology in such patients? So I would like to have all of your opinion.
Initially we had, you're talking to me?
Yeah, anyone can answer.
Initially, in such cases, we used to subject them to palliative chemotherapy, and after completing the course of treatment, whatever chemotherapy he received, patient still had a stable disease, very good performance status. Then the medical oncologist would push us to do the surgery in those cases. But of late, we subject these patients, even after 4 cycles of FLOT, we will go again, we'll go in.
So in my experience in stomach cancer, the patients coming with this, like limited number of patients coming with that category, but we prefer in our center that we should finish our chemotherapy first, all chemotherapy. 2 problems. First of all, it's a signature biology, so it's going to be a poor biology. Other thing is, there's no clear-cut evidence on what time frame you're going to select a patient for surgery. So I prefer to finish all chemotherapy first. So that will be like 4+4 for FLOT, or if they're giving EOX, then 3+3. And after that, we'll reassess the patient for surgical evaluation.
Right.
For us, I think assessment of biology, 2 months of chemotherapy is good. If the disease was resectable at the start and remains resectable, and there is a response, for us, that works. In stomach cancer, we really don't have an answer. There are, like the French groups, they like to keep the chemotherapy. They often use HIPEC along with the IV chemotherapy, and they want at least 3 cycles of HIPEC, which is nearly like completion of full cycles of FLOT before going in for a surgery. Whereas, you have people like others like NIPS, 3 months is good, or till a negative cytology. So once they have a negative cytology, they go in for a surgery. So it's not one cohesive group, So this is a very unique case where you have an upfront resectable disease and a short duration of chemotherapy is sufficient. Sometimes you need to give many more doses of chemo with HIPEC, see the biology, and then decide, whether to go in for a surgery. It's a little complex than just the duration of 2 months versus 6 months.
All right.
Yeah, so very practical situation which Dr. Shefali raised, and so we just need to assess a clinical response. So next is so how do you select patients for CRS HIPEC in CS stomach, Dr. Ajesh? So it's just in a responsive disease, or you look at other factors as well, Dr. Ajesh?
So for CA stomach,
yeah. Just to summarize for the students. So most of the things has already been discussed.
Yeah. So to summarize, select patients in carcinoma stomach, we would either take patients who have peritoneal disease or those in the adjuvant setting. So there are two scenarios where CRS plus HIPEC has shown to be of benefit. In the adjuvant setting, we have, it has been looked into where HIPEC has been looked into with the T4 tumors, the N2, and the positive peritoneal cytology, where some form of IP therapy has shown to be of benefit. Whereas in the setting of carcinomatosis, we would select patients, not just the PCI, low volume PCI, probably a cutoff of about 8 or 10, irrespective of the histology, and good performance status. That's what we would look for. So, and the absence of any other sites of metastasis.
So Dr. Diwakar, what is the PCI cutoff for CS stomach for performing CRS and HIPEC?
So, as Dr. Sanket Mehta rightly pointed out, CS stomach is one disease where a lot of evidence is coming now. So our cutoff for non-signet histology is up to 12, and for signet we keep it to 6 to 67. But the most important thing that we see is the disease biology and the response to chemotherapy. If the patient progresses on chemotherapy or they say partial response, probably they are not the right candidate to perform that surgery.
So Dr. Assif, so how do you treat cytology positive CS stomach?
Cytology positive patients, again, in these patients are subjected to chemotherapy first, 4 cycles of chemotherapy, and then CRS and HIPEC.
Okay. So I'll be quickly moving on to the next case because it's already 8:30. So case number 4, again a common practical scenario. A patient 51-year-old evaluated for gallbladder mass, CA 19/9 is 56, taken up for surgery, laparoscopy done, few peritoneal deposits on the right undersurface of the diaphragm, PCI 1. So intent, Dr. Diwakar, what is your approach in such patients?
Unfortunately, it will be palliative only because it's a gallbladder, and I don't know. I don't think it's going to be curative with that low PCI also. I would like to know Dr. Sanket Mehta's view on this.
A very poor experience. Very low PCI also they come back. I mean, I've done 2 cases. I've given up.
Yeah.
They come back in 6 months. And the evidence also, if you look at rare diseases registry, very, very select patients, and yet the median survival is 18 months. I think it's as good as just palliative.
So Dr. Assif, Dr. Ajesh, so a very strong message in cancer.
Yeah. Like I said, as Dr. Sanket said, we have done 3 or 4 cases after discussing in tumor board. But of late, we have recently started a trial with limited peritoneal disease in CA gallbladder. We had started accruing the patients for the trial.
Yeah, so a very strong message. So in gallbladder peritoneal cancer, the outcome is not very, very good. So these are a few articles. So that's all from my side. So this is one trial. So one pilot study which I came across. So it's this from India only. Dr. Agarwal is the PI. So
this is Dr. Abhishek Agarwal.
Sorry, Dr. Agarwal.
Dr. Abhishek Agarwal. Dr. Abhishek Agarwal.
The same you're talking about. Okay.
He has done this study at AIMS, the pilot study. Now we are going ahead and starting a trial on the similar lines at Rajiv Gandhi. The problem with this trial was that he had subjected such patients to CRS and HIPEC without giving prior chemotherapy. So we are starting this. We are starting a trial after palliative chemotherapy or neoadjuvant chemotherapy, whatever you call it. The patient is still responsive, stable disease, good performance. We're starting a trial with limited peritoneal disease. We subject these patients to CRS and HIPEC and see what the outcome is.
Dr. Assif, do you have any idea about the outcome of the study? Just curious.
No, sir, I have not gone through the study. Doctor,
Okay.
the the author of this trial, he is with us now, and he was of the opinion. And we also thought that since these patients are doomed, they have no outcome, only palliative chemotherapy.
Yeah.
So we discussed with medical oncologist colleagues also, and we thought of trying to see if there is any hope for these patients. This very limited peritoneal disease, maybe we can do something for these patients.
Yeah.
And
With
are
that
you
intent, we have started.
trying
What is the
cisplatin
chemotherapy
based?
given to these patients?
Cisplatin based, basically, I think.
Yeah, so this was more like a feasibility study where they looked whether it can be done, whether it's feasible and safe or not. So in that they had concluded only this one. So I don't have the access to full article, but this is what
I think if anywhere evidence can be raised for gallbladder cancer, it is India, and I think I should congratulate the Rajiv Gandhi colleagues that they started this. I think it really needs. It will be really interesting to see how it goes.
Yes.
Absolutely, I agree completely.
Yeah. So I think I'm done with the panel discussion. So 4 interesting cases, all practical scenarios. More for students. It was. So I'm done with Assif Ali. You can take over.
Yeah, and moreover, all needing a thorough tumor board discussion to go through about the patient selection, to select the biology and which patient should get benefit from CRS and HIPEC. And most important message is to achieve a CC0 if we are planning any HIPEC in any situation. So I thank all of the faculty members for enlightening us on this very important topic and practiced selectively in GI and HPB oncology. And Dr. Nikhil, you can conclude telling about the next session and then we can wind up. Yeah.
We haven't decided yet, Dr. Bali. I don't remember.
Right. So we have decided on GIST. I'll highlight. So we decided that we'll take over a GIST in the next couple of sessions, 1 or 2 sessions, and discuss it thoroughly. So I thank you all at the end for contributing your time and experience in enlightening us. And see you in the 3rd Wednesday with the same session. Thank you all. Yeah.
Excellent one. Thank you.
Thank you so much. Thank you so much.
Thank you, everyone. It was an interesting discussion.
Yep. Thank you, Sanjeev. Thank you, Dr. Sanket. Thank you, Dr. Diwakar.
Thank you so much.
Thank you.
Bye.